It's top of the hour, and we should start with the introductions at least. Although the person's presenting today requires no introduction because we all know him, we read about his accomplishments on a daily basis almost over emails. Dr. Jae Hyun Park is the professor and chair of the postgraduate orthodontic program at the Arizona School of Dentistry and Oral Health. He's a diplomate of the American Board of Orthodontics, ABO, where he serves as an examiner and director of their board, representing the Pacific Coast Society of Orthodontists. Dr. Park has received several awards for scientific and clinical excellence, including the Charlie Schulz Award and the Joseph E. Johnson Award from the American Association of Orthodontists. He recently also received the American Association of Orthodontists Foundation grant and a Biomedical Research Award. Since 2008, while working as a full-time faculty member, he has published more than 360 scientific and clinical articles in peer-reviewed orthodontic and dental journals, including 6 cover pages in the AJODO, 3 books, and 23 book chapters. Dr. Park is the editor-in-chief emeritus of the Journal of PCSO and past president of the Arizona State Orthodontic Association. Recently, he received the 2021 Award of Merit from the PCSO and the 2023 AAOF Louise Ada Jarabak Memorial International Teachers and Research Award at the 2023 AAO Annual Session. He has been appointed to be a founding member of the AAO Committee on Conferences and Meetings, and he's currently serving on the AAO Annual Session Doctors Scientific Program Committee in this capacity. Welcome, Dr. Park, and thank you for sharing your knowledge and expertise with us today.
Dr. Roy, thank you so much for your kind introduction. I would like to express my sincere gratitude to the committee for this kind invitation. Good afternoon, ladies and gentlemen. For those who don't know me, my name is Jae Park. I'm the professor and chair of the postgraduate orthodontic program at ASDOH. I also would like to thank you all for joining my virtual presentation today. This is in my screen, you can see my red study published ATSU research newsletter. I received this email 3 days ago, and my research items were the most read research items from our institution. I received, as Dr. Loy mentioned, I received the 2023 AAO Jarabak Award during the AAO annual session. My left side is the Dr. John Callan. He is the AAO president-elect. He will be the AAO president next year. And my right side is Mr. Chris Benson. He is the AOF president. These are the 2023 Cadebo Case Report, Case of the Diplomate of American Board of Orthodontics Case Report Award winners from Japan. And if you have a good case, please submit to the AJODO Clinical Companion. These are the current ABO directors, American Board of Directors, and next year I'll be the ABO president. Today, I would like to present to you my research activities, and if time allows, I would like to have Q&A session with you. First, I will talk about my lab animal studies because we cannot do the animal study in our institution because we don't have facility. But usually I go to Korea during the summer vacation and winter vacation. I continue my animal studies. How can we accentuate tooth movement to close the missing space? I discussed this subject with Dr. Turley in his PCSO Britain section. In this study, we evaluate the effect of the intentionally created socket and extraction socket groups on orthodontic tooth movement and bone remodeling in rabbits. You can see the new bone formation in the intentionally created socket group. We found intentional socket group, osteotomy group, showed more tooth movement than the extraction socket group, and the difference was significant at 2 weeks. At week 2, both groups shows elevated bone remodeling. There was no statistically significant difference in the amount of tooth movement among corticotomy and micro-osteoperforation groups. However, the corticotomy and micro-osteotomy perforation groups show significantly greater tooth movement than the control group. This study aimed to compare the amount of tooth movement after multiple horizontal and single vertical micro-osteoperforations. The effect of the web generated by both techniques was similar, since the amount of tooth movement, bone variables, and trap positive cell counts showed no significant difference between two groups. What about low-level laser therapy, LLRT? This article was published in the JMS Journal of Oromaxillofacial Surgery. We reported that frequent application of LLRT showed no significant effect on optimized tooth movement. In this rat study, we demonstrate the reconstruction of the interdental papilla after hyaluronic acid filler injection. The inflammatory cytokine were localized to the interdental papilla after filler injection. During orthodontic tooth movement, the damaged junctional epithelium might recover rapidly because basal cells of the remaining junctional epithelium. During tooth movement, osteopontin, bone matrix glycoprotein, and osteoblast specific transcription factor may play an important role in differentiation and matrix formation during periodontal remodeling. What happens TM joint during class 2 corrector treatment? This treatment results suggest that functional appliance therapy induced significant morphologic and histologic changes of the condyle and adaptive cellular functions. In this article, we reported in the response to the environmental changes, mandibular condyle and cranial fossa have capability of functional adaptation. The mandibular advancement was applied when the wet was at the pivotal stage. Compared with control group, the mandibular advancement group showed higher cellular activity after 14 days of continuous mandibular advancement. However, the nature of the TM joint growth modification is still not clearly understood. Dr. Orthodontic, my former resident, was the first author of this article. Dr. Orthodontic, second to right, he's now our adjunct faculty, published 7 peer-reviewed articles with me during his residency. As I mentioned, one of his articles was published in the Journal of Dental Research. Furthermore, all of 5 my residents passed the traditional ABO clinical exam during their 26-month program and became board certified orthodontist. And you can see the Dr. Papa far left side. Now I will talk about my clinical research. In this article, we demonstrate that during the total arch distalization of mandible, at force angulation of 26 degrees, the line of force passed through central resistance. In the force angulation above 23 degrees, the whole dentition rotated counterclockwise. This article was recently published in American Journal of Orthodontics and Dentofacial Orthopedics. What about the total distalization of the upper dentition in class 2 correction? Dr. Kojima is #1 expert in finite elementary study, and he is a member of my research team. In a force angulation of 30 degrees, almost bodily distalization of the total upper dentition occurred, but the upper incisor showed considerable lingual tipping due to the effect of the clearance gap and elastic deformation of the arch wire. So to prevent this, we might need a torque. This article was recently published in Seminars in Orthodontics. In this article, we presented 5 challenge cases. I present some cases in today's presentation because I think my residents are attending one and dental students are attending. Let's see this case 2, pre-treatment porous and x-rays. He showed skeletal class 3 pattern with anterior crossbite. How would you treat this case? This is very difficult case. Total distalization with tests around force angulation of minus 15 degrees. Pre-treatment, post-treatment records. What about the whole visualization of the mandibular dentition in class 2 correction? In this article, we demonstrate force angulation of 28 degrees, the line of force passed through central resistance. This article was recently published in ASDOH and selected as cover for the ASDOH. What about the total visualization of upper dentition in class 3 correction? At a force angulation of 28 degrees, the line of force passed through central resistance of the upper whole dentition. So from our published articles, we have these conclusions, and this might be very helpful for the clinicians when they are considering total distalization or total visualization of whole arch dentition. So when the line of force passed through central resistance, force angulation is around 25 to 30 degrees. Our article was recently published in ASDOH. We do a lot of CBCT studies nowadays. In this study, we measure the posterior alveolar space in both arches using CBCT because this information is very important when you are considering distalization. The X-ray posterior alveolar space gradually increased from furcation to apex, but shows no difference in mandibular PAS, posterior alveolar space, and posterior cortical bone thickness was greater in the mandible. So when you are considering distalization, this information is also very important. I was invited as guest editor for the seminars in orthodontics. The title of this issue was Interactions between Orthodontics and Oral and Maxillofacial Surgery. Let's take a look at the article. I invited authors from South Korea, and in my special issue, my colleagues in Korea published this article. The arrow is the lingual cortex of the mandibular body. In patient A, after extraction of lower 8, you can see there is enough space for lower 7 distalization. However, in patient B, after extraction of lower 8, lower 7 distalization is limited by root contact with the lingual cortex of mandibular body. We published this article in ASDOH. To correct class 3, we can use expander and face mask. This is finite elementary study. In this finite elementary study, we use 4 models. Type 1, labiolingual appliance. Type B, paramedian bone expander. Type C, palatal slope bone expander. Type D, conventional tooth bone expander. After activation of RP in paramedian bone expander, and this is after activation of finite face mask after conventional expander. From this study, we reported that paramedian bone expander was more efficient for expansion than the palatal slope bone expander, but was less efficient for the protraction. In class 3 correction, clinicians should consider this information. However, we need more clinical evidence to confirm this. To investigate these findings from finite elementary study, we published clinical research articles, and these are our recent articles related to clinical evidence of bone expander and face mask. This article was featured as cover for the ASDOH. Before I talk about palatal anchorage device, I would like to discuss palatal bone thickness. In our study, there was significantly lower bone thickness in the early mixed dentition group than the other 2 groups. Bone thickness decreased laterally and posteriorly except in the anterior and mid-palatal suture areas in all 3 groups. And this is our bone study. And then, what is the difference in the palatal soft tissue thickness between adolescents and adults? In this article, we found soft tissue thickness of the palatal soft tissue thickness increased from the late mixed dentition to permanent dentition. Soft tissue thickness was measured intraorally with an ultrasonic device, and palatal soft tissue thickness was different from palatal bone thickness. It increased laterally and posteriorly. Now I'll talk about clinical application of temporary anchorage devices, which we frequently use in orthodontics. My colleagues from Germany sent me this information yesterday. I'm currently number one expert in the temporary anchorage device in worldwide. And you can see the expert number one, Jae Park, and Wilmes Benedict is number two. And so if you are not comfortable with using lingual braces, I would like to share an article with you. WJ retractor would be an effective alternative for patients who are reluctant to use labial braces. She was 24 years old. Her chief complaint was the appearance of upper anterior teeth and upper lip. She wanted to move upper lip backward. Instead of lingual braces, other alternative option will be using WJ retractor. WJ retractor consists of three palatal minuscules, anterior and posterior labial hooks. This is before and after. You can see upper first premolars were extracted. Before and after images showing the lip changes and pre and post-treatment volume rendering images and the superimposed volume rendering image. Nowadays in dentistry and orthodontics, we use RRF GBCT. You can consider using palatal plate in class 3 and class 2 correction. These are the patients related with the appliances. Our article was recently published in PIDO Journal. It is a pretty interesting article because we shared this video with our dental student. I would like to share with them. She had a lip incompetence with bimaxillary protrusion and anterior open bite. She had class 2 and 1 molar relationship on her right side and class 1 molar relationship on her left side. Her mom and patient did not want to extract her premolars to correct her protrusion. So modified palatal plate anchorage was used, raised immediately after palatal plate placement and then bruised after 30 months treatment. Pre and post-treatment photos with non-extraction treatment. Because of the difficulty of this case, her treatment time was pretty long. If we extract upper first premolars in this case, treatment time will be much shorter. In this case, her open bite was closed and profile has improved after non-extraction with distalization. The question is, how does the distalization affect airway dimensions? Let's go to this patient again. This is an airway before distalization. You can see before distalization, minimal cross-sectional area was 118 square millimeters. After distalization, you can see minimal cross-sectional area was 75 square millimeters. So this table shows correlation between the minimal cross-sectional area and OSA, obstructive sleep apnea. If the MCA is above 110, there is low risk of OSA. This patient, MCA, minimal cross-sectional area, has been changed from 118 to 75 square millimeters and might affect airway. So we continued our study and we assessed the airway space after total arch distalization. After using palatal plate, either extraction or non-extraction groups, there was significant total arch distalization. There was no significant effect on the transverse dimensions or airway changes after distalization from our study. Left side is palatal plate and the right side is buccal minuscule. The treatment effects of the palatal plates and buccal minuscules are summarized in this table. Palatal plate shows greater distalization and intrusion with less tipping of the upper first molars and more extrusion of the incisors compared to buccal minuscules. I'd like to share our interesting case with you. This is an example from extraction group. To treat this case, orthodontic treatment included extraction of the 4 first premolars and total arch distalization of both arches using palatal plate. This case was chosen as case months of the American Journal of Orthodontics and Dentofacial Orthopedics. Her chief complaint was lip protrusion. Actually, this kind of article should be published in the plastic journal, not orthodontic journal. And you may see why I tell you. Along with the mandibular distalization, class 3 elastics were used for retraction of the mandibular dentition. In the SAP, you can observe dental and soft tissue changes. Total treatment time was 2 years, and 1 year post-treatment pause. You can see significant improvement of our profile. We recently published this article in ASDOH Clinical Companion. 3-year retention porous, 8-year retention porous. Superimposition of pre and post-treatment CBCT image showing significant amount of the anterior retraction. Upper anterior gingival tissue and alveolar bone. Using a small box size, you can see the better CBCT image. You can see bone deposition during the retention phase. Lower anterior gingival tissue and alveolar bone. You can also see the bone deposition during the retention phase. The thick and healthy gingival tissue and the PDL is essential for alveolar bone regeneration. So also you can see here sagittal section views of CBCT of incisors and alveolar bone. What about long-term stability of upper arch distalization in adolescents and adults? In adults, we reported improved skeletal relationship was still present in the long-term evaluations, and there was no negative long-term effect on airway space after upper arch distalization. What about long-term stability upper arch distalization in adults? In this article, the relapse in upper 6 was 12% after distalization. Should upper 8 be extracted before distalization? And frequently, the clinicians ask this question. In the adolescents, after distalization, upper 8s move backward and upward significantly, while they move downward and forward in the control group. Our article was published in ASDOH. In this study, we investigated long-term evaluation of upper molar position after distalization with and without second molar eruption. There was less tipping of the upper first and second molars and distal tipping of the third molars in group 1. Treatment time was shorter for group 2, and the positional change of the upper third molars was insignificant. In the long term, both groups shows favorable position of the third molars. Therefore, it might not be necessary to extract third molars before molar distalization in class 2 adolescents. We published the first edition of the OCR's impact factor, now is 3.1. In this issue, I was invited as the first guest editor. In this systematic review and meta-analysis, we reported distalization of upper molars using tests. However, we need more evidence, and Dr. Bay was also involved in this project. Now, AI is a big issue in orthodontics and dentistry, and this article was recently accepted in seminars in orthodontics. In this study, we reported the use of the AI to predict outcomes of non-extraction treatment of class 2 molar occlusions. AI changes are in green and predictive results are in red. Sella and Nature was used as reference points. In this study, CNNs were used for the machine learning. More than 10 cases of mice articles was published in American Journal of Orthodontics and Dentofacial Orthopedics, and one of our case of mice articles has been selected to receive 2021 College of Diplomat American Board of Orthodontics Case Report of the Year Award during the AOA annual session. This patient has class 3, width was minus 8.4 millimeters, unilateral crossbite, and midline deviation. This case was published in ASDOH. How would you treat this case? During treatment, to correct dental midline and to correct this to distalize mandibular right segment farther, meniscus was relocated from between lower 5 and 6 to between 6 and 7, and a sliding jig was placed. You may see this case is class 4 molar occlusion. Lower 8s were extracted. And this is after or mandibular arch distalization without surgery. Class 3 motor occlusion has been corrected and his profile has been improved. According to the lateral supplementary analysis, Class 3 skeletal pattern has improved. Upper incisors were slightly proclined due to Class 3 elastics at the finishing stage. IMPA and soft tissue profile have improved. You can see here, lower 6 was tipped back after distalization, and our residents are here. Usually it's not body movement. Pre and post-treatment volume rendering images and superimposed volume rendering images. Dr. Tai is also visiting scholar at our program and my research colleague from Japan, and I received Joseph Johnson Award at 2011 Cable Clinic competition. Our research topic was 3D CBCT superimposition. This is our CBCT superimposition review article. NPR images before and after distalization. And left side is 2D superimposition, and the right side is 3D superimposition. After whole arch distalization of mandibular arch, you can see occlusal plane rotation, tip back of the mandibular molars, and intrusion of the terminal tips. After 2-year retention, the midline of the patient was slightly off due to poor retainer wear. After 8-year post-treatment, no significant relapse. This case update was published in the June inaugural issue of the ASDOH Clinical Companion. This article was published in ASDOH. Dr. Tim Turby, Department of the OMS at the University of North Carolina, did a wonderful job for our patient, Dr. Brad. Brad was dental student at the time. In February 2020, we had a panel discussion at the AAO, American Association of Orthodontics Winter Conference about anterior open bite. Next to me is the Dr. Turby from USC, and far left is Dr. Tae Kim, chairman of the Seoul National University in Korea. Brad also did orthodontic treatment before. He showed severe relapse. 7 millimeter anterior open bite and -1 millimeter overjet. Pre-treatment radiograph. Skeletal Class 3 pattern with retrusive upper and lower lips relative to E-plane. You can see asymmetric open bite and posterior and anterior crossbite. Brad's ABO-DI score was 77. If the ABO score is higher than 20, it is a difficult case. So this might be a very difficult case. In the ABO scenario-based clinical exam domain 2, treatment objectives and planning. How would you treat this case? Every day we talk about this with my residents. Surgery might be ideal treatment option for Brad because of the skeletal Class 3 problems. Nemo FAB surgical software was used for the surgical planning. After 21 months of treatment, pre and post-treatment supplementary measurements. Brad also shows irregular mandibular border. What do you do? However, inferior alveolar nerve is close to the mandibular border, inferior border osteotomy. We published this case in ASDOH. In this patient, you can still see asymmetry after 2-jaw surgery. Volume rendering 3D images shows close distance between the inferior alveolar nerve and the different type of genioplasty to correct asymmetry. To reduce damage of the inferior alveolar nerve, there should be minimum of the 6 millimeters of the distance between the nerve and mandibular contouring surgery. Brad's final CLA evaluation score was 24. If the score is less than 27, you can pass ABO case-based clinical exam. In this case, we corrected Class 2 open bite with TAS along with the extraction of upper folds and the lower incisor extraction. These are her composite images. How would you treat this case? Let's review second domain of this case. After periodontal ligament, treatment options are 2-jaw surgery, upper folds and lower 5-6 extractions, or upper folds and lower incisor extractions with mini screws. After discussion with the patients, this treatment option was chosen. What do we have to consider one more incisor extraction? The open anterior extraction site, which could be unattractive, dental midline will not be constant. Compromised anterior coupling, except where there's significant Bolton discrepancy characterized by small lateral incisors and large lower incisors, and potential formation of break triangle. How can we prevent break triangle? The extraction site preparation technique can minimize break triangle formation. I'll show you this technique video to move the tooth to be extracted lingually to preserve labial cortical bone. A central incisor is most frequently extracted because it is easier to establish proper contact between adjacent tooth. In patients below 20 years old, this approach eliminates break triangles. It reduces the prevalence of these problems in patients 20 to 40 years, but does not seem to be helpful in those aged over 40 years. I summarized this article in just this one table. One of my patients at my private office, after treatment, Adelina did not develop break triangle after one lower incisor extraction. Because of her request for early debonding and a thin alveolar bone, her torque on the upper right rib is not ideal. Setup models for our patients. Retraction of meniscus could produce rotation of internal arch around center of resistance, which results in anterior bite deepening. Tests demonstrating intrusion of molars combined with tongue exercise. Ideally, TPA should be 5 millimeters away from the depths of the palate. Post-treatment records. There was a skeletal improvement, which changed from -5.7 to 0.8 millimeter. Upper and lower incisors were retroclined, upper incisors were extruded, and upper posterior teeth were intruded. You can see the improvement of profile using reference lines, subnasal and perpendicular soft tissue chin. This is not surgical case, just the extraction, and you can see significant improvement of the patient profile. CBCT superimposed images. Intrusion of the upper posterior teeth induced counterclockwise rotation of mandible and improved her profile significantly without surgery. We published this article in seminars in orthodontics with our surgeons. In this article, we reported additional aesthetic surgery that can be performed with orthodontic surgery. This article was published in ASDOH Clinical Companion. This patient has skeletal 2 pattern with steep occlusal plane, anterior combined, and long face. This is after her orthodontic surgery. Please also look at the improvement of the relationship between ANS and upper incisor. A counterclockwise rotation of occlusal plane, the mandibular advancement was efficiently performed, and in this case, we extracted upper first premolars. Sarisha, my former resident, also published a review article about asymmetry in Journal of Clinical Orthodontics, and this is the first time they combined 2 issues together. And it was selected for cover of JCO. And this article was published in AJODO. For condylar hyperplasia, we can consider condylar shaving, high, low, and total condylectomies. This article was selected for case of months in AJODO, and we received the 2021 Karevo Case Report of Year Award during the AUA annual session. Dr. Lim is one of research teams in Korea. 21-year-old male with mandibular prognathism and skeletal asymmetry. The right 5 was congenitally missing. Due to the missing teeth, his dental midline was deviated. There was also class 3 polar relationship. This is very difficult case. Because of his insurance and money, he could not do the 2-jaw surgery. So the plan was just only 1-jaw mandibular setback surgery and correct his motor occlusion and profile. and that makes this case very challenging. Cyclometric analysis shows skeletal class 3 pattern with flat occlusal plane, upper and lower dental compensation. Upper arch was narrow on the right side due to the transverse dental alveolar compensation. Because we are only considering lower jaw surgery with the ideal position of the mandible, there was need for expansion of the upper right side and constriction of the upper left side, along with intrusion of upper molars. The intrusion of the upper molars were continued, and to prevent compensatory extrusion of the lower molars, bite raisins were bonded on the lower posterior teeth. 4 months in treatment. Right before surgery, bite raisins were removed, and the lateral open bite, you can see the lateral open bite. Pre-surgery and 1 month post-surgery. Gray shows pre-surgery and blue shows 1 week after surgery. And you can see the significant improvement of the patient skeletal pattern. 9 months after post-surgical orthodontic treatment, and occlusion looks very good. Facial porous, and you can see the significant improvement of the patient facial porous with just only 1 jaw surgery. By upper molar intrusion and incisor extrusion, occlusal plane rotated about 60 degrees clockwise, and this rotation enabled mandibular setback with backward rotation of the mandible. And gray shows pre-treatment and blue shows post-treatment, and you can see the significant improvement of the skeletal pattern and profile after surgery with just 1 jaw surgery. When a patient has a prognatic mandible with low mandibular plane angle, simple mandibular setback along the occlusal plane cannot improve prominent chin. And also, this might cause the vertical bony step between the distal and proximal segments. This problem can be solved by 2 jaw surgery, which we didn't do in this case, by maxillary impaction and mandibular setback with a mandibular backward rotation. Now I'll talk about digital technology, because all these lectures are 1-day lecture, and then I'm just showing in this presentation what I'm doing, because many people who are attending here might not be orthodontists or dentists, so I'm just giving you rough information. So these are all the digital technologies we are using in orthodontics or dentistry. This is our CBCT superimposition review article, and T0 is before treatment and T1 is after expansion of RPE. As you see here, if we use conventional MPR images, before and after reference lines might not be identical. Therefore, linear measurements using these references may not be accurate. We've used 5 different software programs to transform DICOM data into polygon data. On the left side, using ICP method, superimposition was performed, and on the right side, 3D images represent superimposition of T1 on T0 at the cranial base. In this article, because of her class 3 skeletal pattern, after her growth is finished, she did 1 jaw surgery, which is mandibular setback surgery. Virtual images showing the before and after surgery, and in the CBCT images, pre-surgery is shown in red, and the post-treatment is shown in light blue. These are 3D photo superimposition images over CBCT scan by ICP method. In this study, we wanted to compare hard and soft tissue changes produced by Swatch appliances using 3D superimposition technique. By the way, we call this one TP superimposition, Jae Hyun Park superimposition technique. Swatch appliance mainly affect dental alveolar complex. In the early mixed dentition, we can use Swatch appliance, and mandibular anterior crowding was relieved. Before and after, CBCT images were superimposed by TP superimposition method at the cranial base. This table shows the comparison of non-expansion and expansion groups at the first molars. In the expansion group, the values of the first molars were expanded significantly compared to the non-expansion group. In this study, we used the ICP-TP superimposition method to evaluate changes in the mandibular shape using CBCT images. And we made an illustration using CBCT. You can see the amount of tooth movement after expansion using Park CBCT superimposition method. Using Morpheus, we have Morpheus in our clinic, in our orthodontic department, and we have only 3 Morpheus in American orthodontic program among all 74 orthodontic programs. We compared facial aesthetic standards between Miss Paraguay and Miss Korea. In this study, we found that Paraguayans prefer the rectangular face, whereas Koreans prefer long tapered face. Using Morpheus, we completed another study. The Miss Korea group had longer faces but smaller lower lips and chins than did the general population group. I want to talk a little bit about the distal lingual orthodontics because many people want the lingual braces sometimes. I treated Andrea with my former residents, Joe, at our program. My residents are exposed to incognito or harmony, but I will show you a case with Orthodontics today, and this is Korean company. She has severe anterior crowding, and the lower left 7 was rotated. In this combination technique, which is the upper lingual, lower labial, we used upper lingual braces and lower labial braces. Upper occlusal view, like clean check Invisalign, we can see the changes of the upper occlusion. She had severe lower anterior crowding into oral porous after debonding because she was moving. We request to remove her braces during her treatment. Thus, her treatment is not ideal. However, except the anterior coupling, she looks okay. Nowadays, using virtual articulator, we can evaluate the mandibular position. This was published in Journal of Prosthetic Dentistry. CBCT scans data were imported into digital articulator program and merged with intraoral scan data. Then we imported virtual articulator and adjusted to right and left condyle, medial pores, and orbitally. This is all virtual, so you don't have to use face boards and then articulators. This article was published in ASDOH. When you have orthodontic patient who has a TMD symptom, this article will be very useful. I don't have time to talk about this article today. And this is a wire bending machine, and we are the first orthodontic program who received this donation. These are the surgical software programs recently developed by Korean companies. They want to donate this program to our program, and if our residents want to do research, please let me know. Now I'll talk a little bit about my publications. I was recently recognized for my expert in orthodontics as top published author in America worldwide by ExpertScape. Since 2008, while working as a full-time professor, full-time faculty member at ATSU, I published more than 360 peer-reviewed articles and 3 books. These are some of my books and articles. They were published in major orthodontic journals: Pediatric Dentistry, Journal of Oral Maxillary Surgery, and International Journal of Oral Maxillary Surgery, Journal of Prosthetic Dentistry, Journal of Aesthetic and Restorative Dentistry, Journal of Dental Education, Journal of American Dental Association, Journal of Dental Research. Our articles have been selected as cover for the journals, and I have worked as a guest editor, co-author, and editor of the books. My 3rd book, TED in Clinical Orthodontics, with 69 chapters, was published recently. The 4th was written by Dr. Barris, editor-in-chief of American Journal of Orthodontics, and Dental Orthopedics, and my book reviews. This book has been added to American Board of Orthodontics scenario-based clinical exam reading list after strict review process. Now I'll talk about my research collaborations. These are my national and international oromaxillofacial surgeons who helped me to perform our research and case successfully, and also their reviews for the American Journal of Orthodontics. And these are my national and international bone biology scientists who helped me to perform research successfully. And these are my national and international oromaxillofacial radiologists who helped us to perform research successfully. Now I'll talk about research funding. Our external research was funded by a variety of sources, including nonprofit organizations and corporations. Recently, we were funded by AOF for a teledentistry study. Over several years, the AOF Foundation Award Program has provided more than $13.8 million in funding. And recently, I was appointed as American Association of Orthodontics Foundation Rapid Assessment of Evidence Review Panel. In this review committee, including myself, we have only 3 panelists. Now I'll talk about the editorial board of journals. I'm currently working as an acting editor of the AJODO because Dr. Bosch balance has health issue. And the AJODO, American Journal of Orthodontics, is the highest ranked orthodontic journal by several citations. I also served the editorial board member of the several international peer-reviewed orthodontic and dental journals, including associate editor of the 5 peer-reviewed journals. As you see here, the Journal of Aesthetic, Restorative, and Dentistry, they have now impact factor is 3.1. So I envision that now I conclude my presentation today, and I envision ATSU Orthodontics as a leading global program offering an environment that guides and prepares dental students and orthodontic residents to become community and global leaders thanks to ASDOH's outstanding teaching, training, patient care, and community service in harmony with collegial and collegial environment among faculty, staff, residents, and students. I'm going to express my great appreciation of all those who helped me carry out research. Far left, Dr. Papa, Dr. John, and also at far right, you can see Jen. These are all my residents and faculty members, and I really appreciate all their support and help. This is my contact information, Jae Park at ATSU. If you have any questions, please contact me. Thank you very much for joining my virtual presentation today, and have a wonderful day. And if you have any questions, please let me know. Dr. Roy, the floor is yours.
Thank you, Dr. Park. That was amazing. And that was just the most comprehensive in preview and in-depth, also an in-depth peeking into your world of research. I was just wondering if any of the audience member has any questions for Dr. Park right now. Please unmute yourself and shoot the question.
I have a question, Dr. Roy.
Yes, Dr. Jackson.
Thank you, Dr. Park. That was so amazing. And the work that you're doing to help the patients is just, it just leaves you breathless. So thank you so much for everything that you do for the patients, for ATSU, for the community, and globally. And so I have 2 questions for you as I think about the Research Institute and the work that we're doing is, one, how do you balance all of the things that you do? And then the second thing is, what is your secret of identifying collaborations globally, and how do you actually build those collaborations? So how do you balance all these things, and how do you, can you share some some secrets about how you find and build those global collaborations. Thank you.
Thank you so much for your questions, and I really appreciate it. First, I'm really honored to be here and then presenting those things. And then if you give me another opportunity, I'll present also other materials. For balancing my life, right now I'm doing the ASDOH acting internship, and usually I receive the 20 to 30 manuscripts per day. I was shocked, and then I start this job for 2 months ago. But luckily, I have many people who are helping me worldwide for the reviewing those articles. And then also I have to select several associate editors, finite elementary studies, systemic reviews, and then so on. And also at school, we have full-time faculty members and Jen and staff, and then for residents. And also they are helping me a lot. So, and also at home, my wife is also helping me. And then I have good supporters helping me, especially nationally and internationally. I have really, really good reviewers because I want to maintain the high quality of the American Journal of Orthodontics and other journals, high quality. And all the reviewers are very cooperative. And when I have a lecture in other countries, I always visit my reviewers and my supporters and then have a good relationship with them. And then sometimes they come to America and visit our program. So I think because of the good supporters and helpers, including my residents and my faculty members, and then Jen and our staff, I think I'm still surviving. I think that can be answer for the first question. Second question is for our school is in Arizona, not in California. So if they want to come from the East, from Asian countries, they have to come to the LA, California first, and then come to our school. And then if my colleagues from Europe, if they want to come, if I'm in New York or California, easy for them to come. But Arizona is a little bit remote from the California. But since that ATSU has a very good reputation, and when we started our dental school and ortho program, I first at the time I was thinking, what should I do in order to make our program and make our dental school famous? And then the solution was only publication. So I worked hard, and then while I'm working it, I saw many good researchers and the reviewers and other peoples, and then those people are helping me, and I still can do some kind of things for animal studies or finite elementary studies, which I really like because all those research questions, for example, if you want to improve your clinical research and if you have questions, sometimes you cannot apply to the human beings. In that situation, sometimes we need animal studies, and then also all the grant or the NIH fund that comes from the animal studies, those kind of things, because I'm just only training myself and improving myself for future. Thank you.
Thank you so much.
Are there any other questions for Dr. Park from the audience?
I just wanted to say thank you, Dr. Park. What a great presentation, and what an inspiration you are to our research community at ATSU. And we're so happy to have you on our faculty at ASDOH. I'm hoping you could just talk a little bit about how you approach your writing, because you are arguably the most prolific author across the entire university, and balancing everything else that you do plus teaching is incredibly time consuming. So I know some people set aside time every day for writing. Some people, work in blocks. And I'm wondering if you would be willing to talk a little bit about how you approach your writing.
So the research, when I do research, if I have a interest, some kind of the clinical projects, and then, for example, I am now wondering whether the tooth is moving fast or not during orthodontic treatment. And then I go to the PubMed and then check all the keywords and related with the clinical articles related my interest. And then I select several articles which was recently published, not the old one, according to their impact factors. And usually we go to the AJOD, American Journal of Orthodontics, or Anglo Orthodontics, or OCR, Orthodontics and Craniofacial Research. And they select the best articles. And also I go to the systematic review and meta-analysis where we have published so far in their subjects. And then I just read abstract and then read everything through. And then while I'm reading those articles, everybody in this group take not too much time. And then after reading it, I just summarized in the half page whatever I read from those articles and then put the citation. And then after I have about 10 pages, all the summaries of what has been published last 3 to 5 years, I get some kind of idea. And it doesn't take too much time. And then it's about half-day work if you have time, if you're not bothered by the residents, right? So, and then after that, from there, because always nowadays, because I have many publications, most of the interest in orthodontics are my published articles. So it's easy for me now to search for my own articles and then revise those text and then those kind of things. So it's much easier than before. So that's the way that I do it. And also, you're also very helpful. And then also, our school has also writing system. I don't use a lot, but for the residents, I strongly recommend them use that. Thank you.
Thank you for your questions. And thank you, Dr. Park, for this amazingly informative session and answering all our audience members' questions. Since it's almost the hour when we are supposed to conclude, if we don't have any other questions for Dr. Park, we'll just conclude for today and give everyone 1 precious minute back of Thursday afternoon. Thank you, Dr. Park, and I hope to see you again with us. It was amazing, and thank you for your time. Thank you all.
Thank you so much for everything. Thank you, Anne. Thank you, Dr. Roy. Thank you, Dr. Jackson. And thank you, Andy. Bye-bye.
Bye.
Bye. Bye. Thank you.